Okay, so we'll move forward with the second part of the discussion regarding hyperparathyroidism, focusing now specifically on primary hyperparathyroidism, which does, as we talked about last time, occur due to hypersecretion of parathyroid hormone relative to serum calcium. The majority, specifically 80 to 90% of cases, result from a single adenoma, whereas 10 to 20% are associated with either multiglandular hyperplasia or multiple adenomas, the umbrella term of multiglandular parathyroid disease being used to describe these. Now, it's important to recognize that the multiglandular hyperplasia being talked about here is to be distinguished from multigland hyperplasia, which occurs with secondary and tertiary hyperparathyroidism related to renal failure, which is kind of a topic for another day. As we touched upon also in the previous discussion, parathyroid cancer is a severe but fortunately rare cause of primary hyperparathyroidism, accounting for only about 1% of cases. Primary hyperparathyroidism seen in about 25 out of 100,000 U.S. patients, so the incidence 25 out of 100,000. As with many endocrine pathologies, females are affected more commonly, and the most common age ranges to present with primary hyperparathyroidism is between the ages of 50 and 80. The majority of cases of primary hyperparathyroidism are sporadic, but some predisposing causes have been documented. Radiation exposure has been associated, for example, with increased incidence of primary hyperparathyroidism. A notable historic example of this being that of cleanup workers after the 1986 nuclear mishap at Chernobyl, having a 23% incidence of primary hyperparathyroidism having developed over the years relative to a general Russian population risk of 0.025%. So a difference of 1 in 4 approximately versus 1 in 4,000. So radiation exposure can be an inciting cause. There's also a number of genetic mutations that have been implicated in causing primary hyperparathyroidism. PRAD1, for example, is a cyclin gene on chromosome 11, alterations of which have been associated with 20 to 40% of sporadic adenomas, as well as some B-cell lymphomas and squamous cell head and neck cancers. But many of the, or a significant number at least, of the parathyroid adenomas which are encountered are actually related to a PRAD1 oncogene. Parathyroid hyperplasia, meanwhile, is a common component of both MEN1 and MEN2A, as well as two non-MEN familial syndromes, familial isolated hyperparathyroidism, or FIHP, and the rare but interesting familial hyperparathyroidism jaw tumor syndrome. As they are still conditions asked about occasionally on standardized testing, let's briefly look at the multiple endocrine neoplasia syndromes. You've got primarily MEN1, MEN2A, and MEN2B. MEN1's the 3 Ps, but one of the Ps you have to remember is not pheochromocytoma. So this is parathyroid hyperplasia, pancreatic neuroendocrine tumors, and pituitary adenomas. MEN2A, meanwhile, medullary thyroid cancer, accompanied frequently with pheochromocytoma, and also parathyroid hyperplasia. MEN2B doesn't involve parathyroids, but just for completeness sake, we'll mention it here. That's medullary thyroid cancer and pheochromocytoma, and then you again drop the parathyroid hyperplasia and kind of add, if you will, mucosal neuromas and marfanoid habitus. The MEN syndromes, the majority of them are transmitted autosomal dominantly, but with variable expressivity. So in relation to hyperparathyroidism, our interest is confined to MEN1 and MEN2A. Let's just look at each of these briefly. Parathyroid hyperplasia is seen in almost all cases, 97% specifically of MEN1 syndromes. And this is a hyperparathyroidism which occurs at an earlier age and usually has a milder hypercalcemia than many of the spontaneous parathyroid adenoma related cases of hypercalcemia. Treatment is a 4-gland parathyroidectomy with reimplantation versus a 3.5 gland resection with small clips being placed at the remaining half gland just in case the site becomes a problem. So parathyroid hyperplasia is overwhelmingly the most common tumor involved in MEN1 syndromes. A significant number of patients also have pancreatic neuroendocrine tumors. Gastrinomas are the most common type of these. Insulinoma is the overall most common type of pancreatic neuroendocrine tumor, but the most common type of pancreatic neuroendocrine tumor associated with MEN1 are gastrinomas. And specifically, the MEN1 gastrinomas are usually in the duodenal wall, not necessarily the pancreas itself. And frequently, there's maybe multiple tumors present, so it may be multifocal. Pituitary adenomas, also frequently seen with MEN1, usually presenting as prolactinomas, or prolactinomas which present with galactorrhea and amenorrhea in females or hypogonadism in men. Other manifestations include growth hormone excess, which can lead to acromegaly, can also be seen with MEN1. There are other MEN1 tumors which can occur. As we talk about in a separate lecture, adrenocortical cancer is amongst these, as well as bronchial and thymic carcinoids and benign thyroid tumors. Contrasted with MEN1, only a minority of patients with MEN2A have parathyroid hyperplasia. Specifically, about 1 out of 5 MEN2A cases will have parathyroid hyperplasia as a component. The more common disease processes and more common tumors seen in MEN2A are, of course, medullary thyroid cancer and pheochromocytoma. And beware of this as a question. This is a not infrequently asked question on standardized testing. And they'll give you a thyroid nodule, ultimately worked around the point of it being a medullary thyroid cancer. And you have to remember to work up the pheochromocytoma prior to committing the patient to any surgery for the medullary thyroid cancer. And that's just equally important in the real world as well as in testing, because certainly if you subject a patient with a pheochromocytoma who is unblocked and unprepared pharmacologically appropriately to anesthesia, then the outcomes can often be bad. Patients found to have primary hyperparathyroidism with a significant family history, but in whom MEN is ruled out, are felt to represent familial isolated hyperparathyroidism. This is an interestingly heterogeneous process in that the majority of patients have multiglandular disease, but it's split between multiple adenomas and hyperplasia. A significant number also, it's important to note, of these patients, specifically around a third of these patients, develop hypercalcemic crisis. So these patients can come in and present not infrequently with a severe presentation of hypercalcemia, which will result in the need for acute surgical care. So these can be hyperparathyroidism occurring due to multiglandular disease from adenomas or from hyperplasia, and a third of these patients have severe disease to the point of presenting with hyperparathyroid or hypercalcemic crisis. Familial hyperparathyroidism jaw syndrome is also noteworthy in that while the majority of the patients have hyperparathyroidism due to a benign cause, 15% actually have parathyroid cancer. And parathyroid cancer is extremely rare, but it occurs with significant frequency in this condition of familial hyperparathyroidism jaw syndrome. Additionally, these patients suffer from these patients suffer from ossifying fibromas of the jaw, which, as you can see in this picture here and the scans here, can ultimately become severely deforming if not treated in a timely fashion. So familial hyperparathyroidism jaw syndrome, parathyroid adenomas, or even parathyroid cancer, along with ossifying fibromas of the jaw. So although they are the exception rather than the rule, genetic syndromes should be considered and referral to a genetic specialist made in a number of cases of hyperparathyroidism. The indications specifically are if the hyperparathyroidism is presenting in young patients, specifically less than 30 years old, or if the patient's found to have multiglandular disease, or if they're found to have a parathyroid cancer, or if a significant family history is present. So significant family history, presence of parathyroid cancer, presence of hyperparathyroidism at an age less than 30, or in patients that have multiglandular disease, then consideration should be given to referring the patient for genetic evaluation. May help them avoid or mitigate other disease processes. It may be important in relation to a number of their family members for screening, etc. Once again, though, the majority of hyperparathyroid patients you will encounter will be found to have sporadically occurring single adenomas. And this diagnosis can typically be confirmed with, as we talked about last time, documentation of three things: elevated calcium levels, elevated PTH levels, and elevated urinary calcium levels. If you've got these triad of findings, you've essentially secured the diagnosis of hyperparathyroidism, and these patients of primary hyperparathyroidism, and these patients warrant surgical evaluation. Who, though, should ultimately undergo surgical or operative intervention? Unless anesthesia is contraindicated, any symptomatic patient, as the guidelines say here, as published in the Journal of Bone and Mineral Research from several years ago, any symptomatic primary hyperparathyroid patient, unless anesthesia is contraindicated, should undergo parathyroidectomy. So any symptomatic patient, they need surgery. What are symptoms? Well, as we talked about last time, historically, this was typically severe bone disease, but in the modern era, it's usually one or more of the stones, groans, and psychogenic overtones that we talked about last time. As we're talking about symptoms, though, it must be appreciated that many of these symptoms can be quite subtle, if you will, the asymptomatic symptoms, if you will. So, patients that come in, maybe they're just having some fatigue or feeling depressed or anxious, or an increased level of irritability. They may describe anorexia or some mild to moderate cognitive impairment or poor concentration. So these are a number of examples of kind of some of the mild symptomatology that hyperparathyroidism can cause patients to present with. And so it's important that you have a high index of suspicion for symptoms in these patients that you've found to have significant hypercalcemia with. What about truly asymptomatic cases, though? Well, surgery is still indicated if the calcium elevation is anything more than mild, as highlighted in the red here on the guidelines, or if there's any evidence of osteopenia on a DEXA scan or other formal evaluation looking for osteopenia or osteoporosis, so any early bone disease, if the renal labs are off, and all comers with primary hyperparathyroidism occurring at less than the age of 50. So even if you don't have symptoms, if your calcium is significantly elevated, that's an indication you've got any evidence of bone breakdown or osteopenia developing. That's an indication if your renal labs are off, or if it's occurring at an age less than 50. Even then, if the patient is truly asymptomatic but still without any of these criteria, the consensus still is that it's reasonable and appropriate to consider surgery based on data demonstrating significant risk for osteoporosis and cardiac issues in the future on patients that have prolonged hyperparathyroidism, which isn't treated. So primary hyperparathyroidism is a disease in which we are and need to be surgically aggressive. In point of fact, other than for comorbid complicating factors preventing me from operating, in almost 30 years of practice now, I've actually only recommended against surgery in one case, which just coincidentally was within the last several weeks in my office, a completely asymptomatic 87-year-old healthy male with mildly elevated PTH, mildly elevated calcium, and no issues with osteopenia whatsoever, no symptoms that I could track down, no issues with their kidney. And, this guy's 87 and he's doing that good. Kind of, it's not broke, don't fix it. We did not offer him surgery, but the vast majority of patients with primary hyperparathyroidism should undergo parathyroidectomy. Okay, so once the diagnosis of hyperparathyroidism has been made with lab testing and the decision to operate has been made, considering the labs and the clinical context, then it's recommended that the patient have localization imaging to help facilitate surgery. And that's highlighted here in the yellow and the orange. But to reiterate, these are localization studies. They're not diagnostic studies. The diagnosis is made by laboratory evaluation coupled with clinical examination. These imaging studies are for purposes of localization in patients that have the diagnosis and the decision has been made that operative intervention needs to be pursued. First line in localization is, in most authorities' opinions, a sestamibi scan. And typically we'll also get a neck ultrasound as well. So a standard sestamibi exam and nuclear medicine to look for the parathyroid, which lights up abnormally, but also a neck ultrasound, which also helps in looking for significantly enlarged parathyroid glands, but just as much, if not more so, to look for concurrent thyroid nodules, which may be pertinent to be aware of because it's kind of bad form to perform a neck exploration with parathyroidectomy and leave a thyroid cancer behind that you subsequently find out about. So most of the time in these patients, you've made the diagnosis, you've decided to operate, you're going to do a localizing study, typically a sestamibi scan with an ultrasound to help allow or facilitate a selective or less invasive or minimally invasive parathyroidectomy. And by minimally invasive, I just mean you're not doing a 4-gland dissection with biopsying all of the glands. This does not mean you're doing some what I think are ridiculous procedures with endoscopic procedures in the neck and stuff and calling that minimally invasive. It's tough to get less minimally invasive or more minimally invasive, I guess the right way to say it would be, than, you know, a small partial collar incision made in the setting of a localized, preoperatively localized parathyroid. If your sestamibi and your ultrasound are equivocal or not helpful or confusing in these uncommon scenarios, because usually the sestamibi and the ultrasound will give you information you need, but in the uncommon scenario when a patient with primary hyperparathyroidism has indeterminate findings, then other studies such as PET scans, more sophisticated nuclear medicine studies, or even selective venous sampling for PTH can be helpful. But in such instances, though, I'll just go and typically talk to the nuc med radiologist or another member of the radiology team to get guidance and to apply it to that individual case before, you know, moving forward. So if the first line of localization doesn't work, then typically I'm going to talk to the radiologist to come up with a plan for subsequent localization attempts. Depending on how good you feel about your preoperative localization, as well as other factors that we'll touch upon, you then have to decide upon your operative approach. For me, and I think for most surgeons nowadays, this is going to be a selective parathyroidectomy with intraoperative PTH monitoring. Regardless of whether one favors 4-gland or selective exploration, it is critical the operating surgeon have a good command of normal parathyroid anatomy as well as variants. Let's just start out with something very basic. How many parathyroid glands do people have? Well, autopsy studies suggest that approximately 90% of humans have 4 parathyroid glands. Approximately 10% have more than 4 parathyroid glands. It's rare that you'll have a lower number, you say 2 or 3 parathyroid glands. That's exceedingly rare. And the majority of patients, 90% specifically, or of humans, because it's based on autopsy studies, not all of these patients were patients, but 90% of humans will have 4 parathyroid glands. About 10% will have extra glands, but only rarely do you have less than 4 parathyroid glands. Most of the time as well, all four of the glands, so not just the inferior, but also the superior parathyroids, are supplied by the inferior thyroidal artery. So the inferior thyroidal artery supplies the blood supply in the majority of instances to all four parathyroid glands. And this is kind of helpful to keep in mind if you're struggling a little bit to find where the parathyroid is, where the pathologic parathyroid adenoma is at. It can sometimes be helpful to actually follow the course of the inferior thyroid artery and look for significant dilatation of blood vessels, as that may be a branch that's supplying the parathyroid adenoma. The superior parathyroids are fourth branchial pouch derivatives, and as such are embryologically associated with the thyroid. They typically lie superior to the inferior thyroid artery and posterior to the recurrent laryngeal nerve. Ectopic variant locations for superior thyroid glands are within the carotid sheath and within the thyroid itself. In other instances, enlargement of the superior parathyroids can cause posterior displacement of formerly typically located glands, causing them to kind of fall back posterior to the pharynx or beside the esophagus. So if you're having trouble finding a superior parathyroid, think about the embryologic ectopic locations of being within the thyroid gland itself or within the carotid sheath, or as they, even if they start out when they're normal sized and normal location, they can kind of displace posteriorly back by the esophagus or posterior to the pharynx. It's very rare for parathyroid glands to be found lateral to the carotid sheath. So this can kind of be a limit point for your dissection when searching for ectopic glands. You don't need to go out lateral to the carotid sheath. And again, we mentioned getting an ultrasound preoperatively. This is one of the things that the preoperative ultrasound can be helpful for, is finding a parathyroid gland that's actually within the thyroid itself, and that's usually a ectopic variant for a superior parathyroid. I had a case like that a couple years ago where the offending parathyroid gland, the parathyroid adenoma, was actually within the thyroid, and was very helpful to have a high index of suspicion for that, or to have a high suspicion of that, I should say, based upon the preoperative ultrasound. It saved us a lot of time in the operating room. Inferior parathyroid glands, meanwhile, typically lie inferior to the inferior thyroid artery and anterior to the recurrent laryngeal nerve. So, again, the recurrent laryngeal nerve kind of starting out here a little bit more lateral, then as you go up into the neck comes slightly more medial, and then ends up going into the arytenoids and its superior aspect. So it makes sense that the superior parathyroids tend to be posterior to it. The inferior parathyroids in normal location tend to be anterior to it. Inferior parathyroid glands are fourth branchial pouch derivatives, and so they're associated with thymic tissue, and they have a longer path of embryologic descent, which translates to a higher incidence of ectopic occurrence. So it's more common to have inferior parathyroids be in ectopic locations. They can range from as high as above the superior parathyroids, lateral to the upper thyroid pole, to as low as down in the mediastinal thymic tissue. In similar fashion as to superior parathyroids, there can be so-called acquired ectopic parathyroids, where as they enlarge, they fall down into the mediastinum along the thyrothymic tissue. So when significantly enlarged, inferior parathyroid glands fall down, as contrasted to superior parathyroid glands, which fall back. And here's kind of a schematic of the path along which, this is the head up here to the right, inferiors to the left here. This is the thyrothymic tract along which the acquired ectopics can fall down into the upper mediastinum, again along the thyrothymic ligament. Now, it's important that while searching for possible ectopic inferior parathyroids, not to prematurely transect the thyrothymic tissue here. You don't want to take this tissue until you've got the parathyroid gland, because what can happen, so basically what you want to do is you want to mobilize the inferior thyroid up, but in the process of doing that, be kind of teasing this thyroid tissue up while you're looking for the gland, because if you transect it when you're at this point, the mediastinal parathyroid gland may fall more inferior into the mediastinum and no longer be reachable from a collar incision. So tease things up without transecting the tissue prematurely in order to avoid that pitfall. So just to go back to this on the recurrent laryngeal nerve, I want to emphasize this again because it is of vital importance that the operating surgeon appreciate the anatomic course of the recurrent laryngeal nerve. It comes into the inferior aspect of the neck running along the esophagus, so a little bit more lateral down here. Then in the mid-neck position, it typically lies in the tracheoesophageal groove. So over most of the dissection that you'll be doing when doing a thyroidectomy or parathyroidectomy, it's going to be in the tracheoesophageal groove. But then in its superior aspect, it becomes more anterior and is therefore most vulnerable at that point to injury as it dives into the arytenoids up here. And you have to really be careful, particularly when you're in the region of the typical superior parathyroid glands here, not to injure the nerve and to have a knowledge of where it's at. Now, I don't necessarily advocate going out and always identifying the nerve, but you definitely want to hug the thyroid, know where the recurrent laryngeal nerve is going to be running, and be very judicious with your dissection there. Also important to know about the superior laryngeal nerve, and basically you just want to hug the superior parathyroid when doing these dissections so as you don't also have a potential to injure the superior laryngeal nerve here. Some variant of a collar incision is favored in most cases, usually about 2 centimeters proximal to the sternal notch, 1 centimeter inferior to the cricoid cartilage. And typically, I'll just look for a line in the neck that's at that basic or near that level, and so you can hide it kind of cosmetically. And their smaller incisions are possible, particularly when one is very comfortable with preoperative localization, but you don't want the incision to minimize doing the case safely, certainly. But we can usually do these incisions through fairly, or do these procedures through a fairly cosmetic incision if we're just judicious in how we place the incision and just take our time. It is important to get good neck extension, so get a roll under the shoulder, use a donut on the head to get that good extension. For obese patients, it's sometimes helpful to actually tape the soft tissues of the chest wall and then retract those inferiorly just to keep the underlying soft tissues out of the way. Video or endoscopic parathyroidectomy, I think most of the literature shows a slower, more expensive, no better outcomes. And I think with these small incisions we can do just in the standard fashion probably meets the definition of stupid. So not a fan or an advocate for endoscopic procedures here, which seem a bit ridiculous to me. There is still legitimate controversy, though, between a traditional 4-gland parathyroid exploration and a single gland surgery, the single gland surgery being guided typically by intraoperative PTH assays and preoperative localization. A 2020 Cochrane analysis contrasted or documented the data comparing minimally invasive or single gland parathyroidectomy with as compared to 4-gland parathyroidectomy, and found that basically you had close to equivalence here. If you're looking at 6-month normal calcemia, 97% for the single gland, 99% for the 4-gland, 5-year normal calcemia, 90 and 95%. So maybe a slight, not statistically relevant, but a slight nod to the 4-gland parathyroidectomy here. But then when you look at complications, that favored the more selective or minimally invasive parathyroidectomy, the single gland parathyroidectomy, with overall short-term complications of 17% as contrasted with 34% in the 4-gland parathyroidectomy. And the majority of those complications were hypocalcemia, as you can see here, 27% for the 4-gland, roughly half of that for the selective parathyroidectomy. Recurrent laryngeal nerve injury, low in both instances.
but maybe a slight cautionary wording here with the minimally invasive parathyroidectomy being 4% versus 2% for the four gland. Perhaps individuals or the surgeons were trying to keep the incision too small, and that might increase the risk of recurrent laryngeal nerve injury. I'm not sure. But basically, if you are looking at single gland parathyroid surgery with the adjuncts of intraoperative PTH and preoperative localization compared to a more traditional four gland parathyroidectomy, there's not a huge difference in the current literature. Back in the 1990s, we were trained, when I was training to do routine four gland explorations. I initially regarded selective or single gland explorations guided by sestamibi and intraoperative PTH assays as heresy. But as both the preoperative localizations and intraoperative PTHs have become increasingly accurate and readily obtainable, the lure of selective exploration has become increasingly difficult to resist. And most surgeons, I think, now favor single gland surgeries unless preoperative localization is indeterminate or family history, imaging, or some other factor suggests multi-gland disease. So most people, I think, will now favor the preoperative localization, PTH assay intraop, and single gland parathyroidectomy. But there are instances when a multi-gland exploration is still necessary. If you do find yourself needing to perform a multi-gland exploration, you will need to biopsy normal or shrunken parathyroids, and it's helpful to know that fat floats and parathyroid sinks. This is a trick Dr. Boudet taught us back when I was in training, and so as we were doing four gland explorations, he would take little pieces of tissue. We weren't sure completely if it was fat or parathyroid, put it in saline, and if it sinks, then it's worth sending to the pathologist to confirm whether it's parathyroid tissue or not. If it floats, then there's no reason to waste the time and effort sending it. And this isn't easy. At least I don't find it easy. Here normal parathyroid glands are fairly subtle in their appearance and can be difficult to distinguish from fat and other tissues. Here you see, looking at these normal parathyroids, these are not large structures, and I find this to be difficult, and that's one reason I'm glad that we actually don't have to very often do four gland, or near as often at least, do four gland explorations anymore. Adenomas, fortunately, are more readily distinguishable from surrounding tissues. First of all, just because they're larger, obviously, but they also tend to have kind of this characteristic maroon coloration as compared to the normal parathyroids, which look a little bit more like fat or other tissues, a little more of a yellowish or light pinkish hue, whereas with a parathyroid, adenomas are typically more of a little bit darker maroon. You can see here this superior parathyroid adenoma. Here's your trachea up here. Here's the recurrent laryngeal nerve. And then just posterior to it, as you would expect for a superior parathyroid, is where this adenoma was found. Here's a couple other appearances. Again, just kind of this characteristic coloration that you can see here. Here's an intrathyroidal one, like the case that I had a few years ago, where the parathyroid adenoma, the superior parathyroid adenoma, was actually found within the thyroid gland itself. PTH assay intraoperatively. I think communication is really important here, particularly in a center like ours where we don't necessarily have enormous volumes. So I'll call the lab the day before, make sure they're locked on, make sure the pre-op nurses are locked on, that, hey, we're going to be doing a PTH assay. And then there's a number of different ways to do this. I think the most effective way is the one that's highlighted in green here, where you get a level preoperatively, and then I also get a level intraoperatively during the manipulation, because you manipulate the parathyroid during the surgical process. So that can sometimes stimulate increased PTH secretion. And so your intraoperative level may actually be higher than your preoperative level. And if you're looking for it to decrease significantly, you may be looking for it to decrease significantly from actually a higher level than you're anticipating based on your pre-op level. So but at the same time, these levels take time to come back sometimes, particularly in, again, institutions where maybe we're not as high a volume. So I'll get the preoperative level. I'll get an intraoperative level right before when I've just, I've got things dissected out here well, and at that point, go ahead and send another level. So you want to, again, be prepared, communicate, have talked to the intraoperative team, have an extra IV in place or some other line that anesthesia can draw off of. You've got the parathyroid dissected out. You're about ready to take the pedicle and take it out. Right then, send another blood level. And then once the parathyroid's been excised and is being sent, and I do still typically send it to the pathologist for frozen section confirmation as well. But as you're waiting on that to come back, then every 10 minutes, I start sending PTH levels because at least in our institution, it takes sometimes 20 minutes plus for these to come back. Occasionally, you'll have a number that's not quite where you want it to be at 10 minutes. And if you've been waiting 20 to 30 minutes already, it's really nice to have another one having been already sent and in the pipeline ready to come back shortly. So I'll tend to send some extra ones of these just to kind of save us time in the operating room. So one pre-op, one intra-op right before you take the parathyroid out, and then 10 minutes thereafter until you get several results back that either confirm that you're good to go or maybe you're going to be motivated or pushed to do a 4-gland exploration. And we can see that the sensitivity, the specificity, the positive predictive value, the negative predictive value, the overall accuracy is quite good here. If your PTH level drops down to 50% of what it is pre-excision. So what you're looking for is a drop in the PTH level by 50% or more, and that's a very good predictor that you're just dealing with single gland disease and you don't need to do a multi-gland exploration in those cases. If it doesn't drop, then you do need to do a multi-gland exploration. If your patient's unfortunate enough to have a parathyroid cancer, then you're going to need a legit collar incision. You're going to need a concurrent thyroidectomy. You may need a central neck dissection, and these are big cases, and this patient's going to need a significant dissection. Again, these patients have a higher risk than typical adenomas of presenting with hyperparathyroid crisis. They'll more commonly have a palpable mass that you see. A number of them will have lymph node metastasis. A third will even have distant metastasis. The treatment is en-bloc resection with concurrent thyroidectomy, and depending upon the extent of disease, often will need a central neck dissection as well. If treated aggressively, though, patients can survive with this, but it is a deadly cancer. Once again, fortunately, quite rare. Only about 5 out of every 10 million in the population will contract this disease. In regards to post-operative management, I'm still a bit uncomfortable. I know a lot of people do, but I'm still a bit uncomfortable sending these patients home the day of surgery, in part due to the potential for an airway-threatening neck hematoma, but more out of concern for hypocalcemia, which is a much more common occurrence post-operatively in these patients, and can lead to potentially severe complications of carpal pedal spasm, laryngospasm, bronchospasm, seizures, prolongation of the QT interval, and cardiac arrhythmias. So hypocalcemia can be a big deal, and it does happen with some significant occurrence post-operatively. There are a number of mechanisms responsible for this, mechanisms by which post-parathyroidectomy patients become hypocalcemic, and these become and kind of make for interesting academic discussions as far as, is it true hypoparathyroidism versus hungry bones, and what the phosphorus does with one as compared to the other, and what the significance of a patient coming into the case with a vitamin D deficiency is. But I'll be honest with you, I have a hard time remembering all of that. So I basically do the same thing I do after total thyroidectomies. I treat all of the patients with 1250 milligrams of calcium carbonate, TID. There's 500 milligrams of elemental calcium in 1250 of calcium carbonate. The recommended amount to supplement these patients with is 1500 elemental calcium carbonate, of elemental calcium daily. So that translates to 1250 of calcium carbonate, TID, and then give them calcitriol, vitamin D in the form of calcitriol. I usually give 0.5 micrograms BID. and then follow their ionized calcium, their magnesium, and their phosphorus every 6 to 8 hours, depending upon how significant any of these deficiencies might become. You might even follow it a little more frequently, depending on what you're needing to do, and if you're needing to do the IV supplementations and things. But so I just treat them all with the calcium carbonate, with the calcitriol, and then closely monitor the ionized calcium, the magnesium, and phosphorus levels, correcting them as needed post-operatively. If they're having issues, here's a nice algorithm from the 2025 up-to-date article on this. If they're having any significant symptoms or cardiac issues, then you'll need to up the ante and actually treat them with IV calcium and monitor them even more closely, maybe every 4 hours, certainly be watching them on telemetry. On the other hand, more often than not, if you've been proactive, things will be fine by post-operative day one, and you send them home at that time. I'll typically keep the calcium and the vitamin D going for about 2 weeks, see them back in the office, and make sure that their levels are okay. And provided they are, then usually stop it after a couple weeks. If they're not, then they may have more of an ongoing issue, maybe an issue ultimately even for endocrinology referral, depending. But you may need to keep the supplementation going for longer in isolated cases. But most of the time, things will settle out and normalize after 2 weeks, particularly if it's just due to like a hungry bone situation or something. Okay, so now that we've reviewed all of that, let's put it into practice with our case study. This is a 56-year-old male, once again, with lethargy and confusion. His past medical history, again, is a reminder: hypertension, coronary artery disease with a past MI, and resultant ischemic cardiomyopathy with an ejection fraction of 35%. He'd had a recent pulmonary embolus and had a significant history of Lynch syndrome with 2 colon cancers, one resected in 1994. And just several months before his presentation here in 2022, he'd had a sigmoid cancer removed with a low anterior resection. Previous procedures are what we talked about there, plus a left inguinal hernia repair, ankle fracture, and repair and cardiac catheterization with drug-eluting stents back in 2019. Physical exam at the time of presentation: he was disheveled, had dry mucous membranes, he was having a lot of diarrhea, which had been an ongoing issue for him since his low anterior resection. Labs: his total calcium was higher than 18. PTH level was significantly elevated at 293. Other electrolytes weren't too terrible, with the exception of some hypomagnesemia and some hypophosphatemia. It's interesting, when you look back at his history, he had actually been documented to have hypercalcemia earlier in the year with elevated PTH and elevated calcium. But again, people fell into the pitfall of utilizing a sestamibi scan as a diagnostic study. A sestamibi was ordered and was reportedly negative. We ultimately found out that wasn't necessarily the case when the study was reviewed, but sestamibi was reportedly negative, and so the workup was dropped at that point, and the patient wasn't followed up from a hypercalcemia standpoint anymore. At the time of his low anterior resection, just several months prior to this presentation, his calcium was still elevated. He had ongoing issues. I think this was kind of a cumulative effect in relation to the dehydration with which the patient presented. It was, in final retrospective analysis, I think, secondary to the hypercalcemia, yes, but also the diarrhea, which had been poorly controlled after his low anterior resection. So again, listed here are his initial labs at the top, but then subsequently a 24-hour urinary calcium was obtained, which was significantly high. So at this point, you basically got the diagnosis of primary hyperparathyroidism, right? You've got significant and confirmed hypercalcemia on several tests. You've got a significantly elevated PTH, and you've got a high urinary calcium level. This patient has primary hyperparathyroidism. Because of his previous history of cancer, the medicine team who initially admitted him got a PTH-RP. That was within normal limits. TSH level was normal, and that's a prudent thing to do if you have any concerns about thyroid issues, particularly hyperthyroidism. You don't want to be manipulating a thyroid gland to do a parathyroidectomy in a patient who's hyperthyroid, you could potentially have issues with thyroid storm, but the TSH level was normal. Vitamin D level was low. And this is kind of a helpful thing to know. We didn't talk about this, but getting vitamin D level, certainly that's very important if you're working up something that's not obviously primary hyperparathyroidism, because a number of disease processes with abnormal vitamin D can be implicated. But even when we have the diagnosis of primary hyperparathyroidism, having a vitamin D level that's low doesn't necessarily affect what you're going to do preoperatively. The literature on that's a little bit mixed. Some people supplement the vitamin D, but then there have been reports of that actually exacerbating the hypercalcemia. So I tend to stay away from that. But what this does tell you is that this patient's going to be a bit prone to hypocalcemia postoperatively once the offending parathyroid gland is taken out. So I'll tend to be a little bit more aggressive with the vitamin D supplementation in those settings of patients that have preoperatively a documented low vitamin D level. A CEA level was also obtained, and that was within normal limits. So the patient did get somewhat extensive cross-sectional imaging. He got a head CT when he first hit the ED, which was understandable given his lethargy and mental status changes. He got a chest CT, which showed the PEs were better, but he now had a left ventricular thrombus. So important that this patient be anticoagulated with as minimal an interruption as possible. Abdominal and pelvic CT was unremarkable. He also got a neck CT, which is, I think, pertinent to look at. You can see here on the neck CT scan, which was obtained, there's a 2 by 1.6 centimeter, what they called indeterminate density nodule, which is at the level of the thoracic inlet, just posterior to the left sternoclavicular joint. Here's the left sternoclavicular joint. Here's this mass right here, just in the upper mediastinum. So kind of a typical location, if you will, for an inferior parathyroid gland, which has, with enlargement, fallen down and become an acquired ectopic inferior parathyroid gland along the thyrothymic ligament in the superior aspect of the left mediastinum. The patient was admitted. He was initially appropriately fluid resuscitated, and then the medicine team put him on LR, which you can argue maybe isn't the best choice since there is some calcium in that, but he got admitted, got resuscitated, which of course is the first step, as we talked about in these patients. And then one of our nephrologists saw him and put in this consult, which was, I think, a pretty astute and helpful one. The nephrologist says he has severe hypercalcemia, but it appears very acute, given that he had a calcium level of 9.7 2 weeks ago. This was around the time of his surgery. Furthermore, he looks extremely dry on clinical exam, so he'll get several liters of saline and will continue lactated ringers. We need to be careful about his fluid status given the CHF, though, and that was a concern here. Regarding giving bisphosphonates, basically just say if this is primary hyperparathyroidism, which it looks like it is, and we're going to do surgery, then it's probably best not to give them. On the other hand, if it turns out to be something else, then it may have a role, just as we talked about in the first discussion. So he got treated with fluids, he got treated with some medications, he got some Cinecal, he got some calcitonin, he did end up getting some permethrin, and his calcium level was able to come down with those measures. He was seen by an ENT surgeon initially, and there's a lot of verbiage here, basically where they essentially just wanted to delay things to the outpatient setting and, work things up further and stuff. But, difficulty with that was this guy was a little bit prone to not necessarily following up, not necessarily being completely compliant with all aspects of his care. And the fact that, every time you interrupt this guy's anticoagulation, that's a bit of a risk, particularly in the outpatient setting. So I saw the patient in consultation, and I'm sorry, should mention that he did also require hemodialysis. I glossed over that. The patient got hemodialysis on 2 days here, which is really what brought his calcium down. as you'll see, the medications didn't have as great of an effect. So this was, pretty severe situation where he actually required hemodialysis. So given that, I felt like the constellation of findings were strongly supportive of primary hyperparathyroidism. I felt that it was reasonable to proceed with parathyroidectomy on a heparin window to help minimize his risk of recurrent issues and avoid the need for interruption of anticoagulation in the future. I did confer with radiology, and they'd actually obtained this sestamibi CT scan, um, or this had been obtained in the past. This was the one that was done that was reportedly negative. We looked at this and was pretty clearly positive. I guess they just missed it because it was ectopic in nature slightly or something. But we went back and reviewed the sestamibi coupled with the CT scan in the past, and it actually was, argued for what we thought was going on, which was a left inferior acquired ectopic parathyroid adenoma. So we took the patient to the operating room. Here's an intraoperative photo. Here's the head up here, superior. Left is on the left of your screen is inferior. Here's the right of the patient. Here's the left. Sternocleidomastoid musculature and strap muscle is retracted here. And as you were going down into the mediastinum here along the thyrothymic ligament, you can see this typical appearing mass. Here's the thyroid retracted up here. So here's the parathyroid adenoma. That, even knowing where it was at, took a little bit of doing to find. Here it is after we've got it more dissected, and so we're essentially getting ready to take the pedicle and excise it. So this is the point at which we sent our second PTA, our second quote-unquote pre-op or pre-excision PTH level. This is Dr. Winter performing the case with me here. Here's what the adenoma looked like after we removed it. And thankfully, the PTH level at our first check went down from a preoperative level of 274 down to 85, meeting that 50% criteria. And so at that point, we completed the case. Here's what our incision looked like on postoperative day 1. So you can see, I think, very cosmetically reasonable incision. And we monitored the patient. We were a little more aggressive. I gave him twice the dose of vitamin D based upon the low vitamin D levels preoperatively. So he got the calcium carbonate TID. He got 1 microgram of calcitriol TID. We monitored his ionized calcium, phosphorus, magnesium, B and P every 8 hours, and had to do a few replacements, but nothing too striking with the replacement. And the patient went on to an uneventful course and has not had any issues with recurrent hypercalcemia, although his diarrhea does continue to require significant management with Lamodal and Imodium, both to keep that diarrhea under control, which is a separate issue more related to his essentially total colectomy state with what's essentially an ileorectal anastomosis. So hypercalcemia can most commonly will present to your office, with patients that have, more of a subacute presentation, but can also present in the critical care setting in very severe cases such as this, and in such cases require a multidisciplinary management, but also can very often be cured with appropriate surgery.